Hi everybody, and welcome to our module on the parathyroid glands. The parathyroid glands are four endocrine glands that are found in the neck located behind the thyroid gland, as shown in this picture at the bottom of the screen. Embryologically, they are formed from the third and fourth pharyngeal pouches, and their job is to secrete parathyroid hormone, which is important for homeostasis of calcium and phosphate. Parathyroid hormone is a protein hormone. This means it is soluble in water and very different from the steroid hormones that are derived from cholesterol. Like most protein hormones, it binds to surface receptors that are largely found in the bones and also in the nephron of the kidney, as we will discuss in the next few slides. The cells that synthesize parathyroid hormone are called the chief cells, and they are found in the parathyroid gland. As I mentioned to you before, parathyroid hormone is important for maintaining levels of both calcium and phosphate. This means it has effects on both calcium and phosphate levels in the plasma. Its main effect is to raise the level of calcium in the plasma. However, it will also lower the level of phosphate in the plasma, and one of the ways in which it lowers the level of phosphate is to increase the amount of phosphate going out in the urine. So you should always remember these three effects as the major effects of parathyroid hormone. Now, some of these effects, as we will see, are due to a direct action of parathyroid hormone. Others of these effects are due to an indirect mechanism via activating vitamin D. There are several different triggers that can lead to the release of parathyroid hormone from the parathyroid glands. The major stimuli for secretion of parathyroid hormone is a low level of calcium in the plasma. This elicits the fastest response from the parathyroid gland. You can also see a rise in the level of parathyroid hormone in response to high plasma levels of phosphate and also to low levels of 1,25 hydroxyl vitamin D, which is the active form of vitamin D. The way that calcium manipulates the release of parathyroid hormone from the parathyroid gland is by binding to calcium sensing receptors, or CASRs. When calcium binds to the calcium sensing receptors, this leads to a drop in the amount of parathyroid hormone released by the glands. Magnesium can also affect the parathyroid glands, and it has a very similar effect on the glands to calcium. An easy way to remember this is to recall that magnesium and calcium are very close to one another on the periodic table of elements. Magnesium and calcium share many similar properties, and thus it makes sense that they should both exert a similar effect on the parathyroid glands. A high magnesium will result in a decrease in the amount of parathyroid hormone released by the glands. This is the same effect as calcium, and this is because magnesium can activate the calcium sensing receptors just like calcium can. Conversely, a low magnesium level will lead to an increase in the amount of parathyroid hormone released by the glands. This is also the same effect as calcium, and this will lead to increased GI and renal magnesium absorption along with calcium, and this will help to maintain the calcium level in the plasma. There is one exception to the rule that magnesium has the same effect as calcium on the parathyroid glands, and that has to do with very low magnesium. If the level of magnesium gets very low, this will inhibit parathyroid hormone release. The reason for this is that some magnesium is required for normal functioning of the CASR. If the level of magnesium is very, very low, there will be abnormal function of the CASRs, and this will lead to a suppression of parathyroid hormone release. And the reason this is important clinically is that you can see hypocalcemia in the setting of severe hypomagnesemia, and that is from inhibition of parathyroid hormone release in the setting of very low magnesium. Another way to remember that calcium and magnesium can have similar effects on the parathyroid gland is to remember that they can both affect the QT interval on the surface EKG. If you look at this tracing on the top right side of the screen here, the QT interval is the interval from the beginning of the QRS complex to the end of the T wave, and it is normal in this example. Low magnesium and low calcium can both cause a prolonged QT interval, as shown on this tracing on the left side of the screen. The QT interval begins here and ends about here. This is a QT interval of about 500 or more milliseconds, and that is very prolonged. Hypercalcemia, on the other hand, can cause a short QT syndrome, as shown in this tracing on the bottom right side of the screen. Hypermagnesemia is not known to cause a short QT, only hypercalcemia. Now let's talk about the effects of parathyroid hormone on the different tissues and cells of the body. In the kidney, parathyroid hormone leads to increased calcium resorption in the distal convoluted tubule. I'll show you a picture of that in a minute. In the proximal tubule, you can see a decrease in the amount of phosphate reabsorption. We will also look at that in a second. And then also in the kidney, you can see an increased synthesis of 1,25 hydroxyl vitamin D, which is the active form of vitamin D. In the GI tract, parathyroid hormone leads to increased calcium and phosphate absorption. This is an indirect effect that occurs via vitamin D. And then finally, in bones, you can see increased calcium and phosphate reabsorption both directly through parathyroid hormone and indirectly via vitamin D. Now, this may confuse you because some of these effects show a rise in the phosphate level in the serum, whereas the kidney will excrete more phosphate. You should always remember that the net effect of parathyroid hormone is to lower the amount of phosphate in the serum, even though it is increasing the absorption in the GI tract and the resorption in the bones. Here's a depiction of the effects of parathyroid hormone on the proximal tubule of the nephrons. Parathyroid hormone inhibits a sodium phosphate cotransporter found in the proximal tubule. This leads to more phosphate being trapped in the urine and thus being excreted with the urine. This will lead to a decrease in the phosphate level in the serum. Also in the proximal tubule, parathyroid hormone increases the conversion of vitamin D to its active form. There is an enzyme found in cells of the proximal tubule called 1-alpha hydroxylase. It converts 25-hydroxyl vitamin D into 1,25-hydroxyl vitamin D, which is the active form of vitamin D, and parathyroid hormone activates this enzyme. I talk about this whole process of activation of vitamin D in more detail in the biochemistry modules. One side note here is that this activation of vitamin D can occur independently of the kidney in diseases like sarcoidosis, and this is a way you get hypercalcemia in sarcoidosis. You have activation of vitamin D in absence of parathyroid hormone stimulation. Here's another depiction of parathyroid hormone effects on the kidney, this time showing the effects on the distal convoluted tubule. Parathyroid hormone can activate a pump that reabsorbs calcium in exchange for sodium. This will pull more calcium out of the urine and into the interstitium and blood and raise the amount of calcium found in the serum. Now I'm going to talk about the effects of parathyroid hormone on bones, and this can be a point of confusion for students because parathyroid hormone has multiple different effects on bone. It can stimulate both bone resorption and formation, and the dominant effect varies with the dosage and timing of administration of parathyroid hormone to cells in the bones. If you administer parathyroid hormone to bone cells and bone tissue continuously, you will see bone resorption and a rise in the serum calcium level. And this is the way the parathyroid hormone works physiologically, to raise the serum calcium level and keep it normal, or to raise it in the setting of hyperparathyroidism. If, however, you administer parathyroid hormone to bone tissue via a low-dose once-daily bolus, you will see increased bone mass and bone formation. And this is the mechanism of action behind the drug teriparatide. Teriparatide is an analog of parathyroid hormone, and it can be used to treat osteoporosis. This can seem counterintuitive. Why would you administer an analog of parathyroid hormone in a weak bone disease when parathyroid hormone causes resorption of bone? The reason teriparatide works is because when administered as a once-daily low-dose bolus, you see bone formation, and therefore it's beneficial in osteoporosis. To understand how parathyroid hormone works on bones, we need to review the types of cells found in bones. The first cell type are the osteoblasts. These are bone-forming cells, and they contain parathyroid hormone receptors, and they can increase bone mass in response to stimulation from parathyroid hormone. The other important cell type found in bones are the osteoclasts. These are bone-resorbing cells. They have no parathyroid hormone receptors, and they are activated indirectly by parathyroid hormone by way of the osteoblasts. When osteoblasts are stimulated by parathyroid hormone, they will synthesize a substance called MCSF. This stands for macrophage colony stimulating factor. It is secreted by the osteoblasts, and this will activate the osteoclasts. Also, when stimulated by parathyroid hormone, osteoblasts will synthesize a surface receptor called RANKL, which stands for receptor activating nuclear factor Kb ligand. This is expressed on the surface of osteoblasts, and osteoclasts have receptors for RANKL so that they can bind and become activated. So both MCSF and RANKL are produced by osteoblasts, and this is the mechanism by which they activate osteoclasts. And I've shown this at the bottom of the screen. The osteoblast makes MCSF. It also expresses RANKL on its surface. The MCSF can stimulate the osteoclast, the RANKL can bind to the osteoclast, and in this